we will move on to our second case. Lanre, would you please like to present your first case?
Thank you, Alan. Could you hear me?
Perfectly.
Okay. Um, so my first case is a case of a male, a 69-year-old male who had a diagnosis of CML, initially in chronic phase in November 2018. The SOCAL score and the ELTS score were intermediate, but he had a comorbidity of hypertension. As it's usual in Nigeria, all patients in chronic phase are started on imatinib because that is the most available, although there are second lines available right now. So he was started on imatinib 400 milligrams a day. He achieved complete hematological remission after about 6 months, within 6 months. Okay, but he failed to achieve molecular and cytogenetic response. After a year, when the BCR-ABL should have dropped to around zero point 0.1 or less than that, his BCR remained high at 6.769% after a year of imatinib. As a result, the dose of imatinib was increased to 600 milligrams daily. But despite that, he lost his hematological response and he started having leukocytosis. A sample was sent for tyrosine kinase domain mutation in 2019 in May, and it showed M244V. Luckily, M244V responds to both nilotinib and dasatinib. So he was commenced on dasatinib at 50 milligrams initially in 2021. He started, yeah, the usual dose of dasatinib is 100 milligrams, but he had thrombocytopenia. So at that time, Professor Joe was once seeing him, and he advised that he started the dasatinib at a lower dose of 50 milligram because of the thrombocytopenia, hoping that the dasatinib will push him into complete hematological remission, and then his platelet counts will come back to normal. So he started dasatinib at 50 milligrams initially on alternate days because of thrombocytopenia. However, at that dose, it seemed as if the dosing of dasatinib was suboptimal as his white blood cell counts kept rising. So he had to go on to dasatinib 50 milligrams daily, but using a thrombomimetic agent. He was using L-Thrombopac. And if you're familiar with our currency, a single month supply of L-Thrombopac is worth about 250,000 naira, which that's about, I would say that's about maybe like 500 pounds per month. So it was a big financial burden on the family, but somehow they managed to pull through with their thromboback support. Despite the fact that he didn't achieve complete hematological remission, we were constrained to increase the dasatinib dose because of the thrombocytopenia. So he continued on dasatinib 50 milligrams daily with leukocytosis, not achieving complete hematological remission even within a year after commencing it. And then he developed renal abscess. He had to be admitted in the hospital. While in the hospital, the renal abscess he was taken to surgery where the renal abscess was drained. After surgery, he became neutropenic, developed neutropenic sepsis, developed refractory thrombocytopenia. We had to keep transfusing him with platelet pools. As a result, I reached out to IFE, which is the referral center in Nigeria for the TKIs, and explained to them that he wasn't tolerating the dasatinib well. Luckily, because nilotinib will also responds to that, because that mutation also responds to nilotinib, he was switched to nilotinib 400 milligram BD in 2022. He achieved complete hematological remission within 3 months on nilotinib, but due to financial constraints, he was unable to repeat his BCR-ABL. After about a year on nilotinib, I think a supply of nilotinib was sent, but it hadn't been cleared yet, and he ran out of nilotinib. In the meantime, between getting the nilotinib back, he was switched back to dasatinib because he couldn't be left off TKI since he was yet to achieve cytogenetic and molecular remission. Within a month of recommencing dasatinib, he developed refractory thrombocytopenia. He was admitted. We gave him we were giving him about 2 poles of platelets daily. But despite that, his platelet counts were remaining persistently below 10. And unfortunately, he passed away. Now he's 69 years old. I'm aware that at his age he could still have been transplanted, but I believe we needed to get him into remission. I mean, some sort of remission, cytogenetic remission or molecular remission before considering transplant, because I feel if we could have done that, he could have afforded, maybe he could have gotten some help to get a transplant outside the country. So I'd like to know what we could have done differently in managing this patient that would probably have prolonged his life.
Naeem, the floor is yours.
Okay, thank you very much. Interesting case, actually, and it's difficult to comment from the retrospective point of view that could have been done differently. But may I know that when he developed refractory thrombocytopenia, whether a bone marrow was done at that time, and was the patient still in chronic phase or was in the advanced phase of the disease at that time?
A bone marrow aspirate was done. He was in advanced. He was in the accelerated phase, if I can use that term.
Yeah, sure. Yeah, I think that's understandable. There are two things over here. And certainly, despite although V244V, M244V is really sensitive to almost all the TKIs, especially dasatinib, nilotinib, even bosutinib and seminib and ponatinib also. But I have a feeling that there is probably an underlying disease acceleration already present over there, and also there may be an intrinsic resistance. As you very well know, that BCR is the intrinsic resistance is in 40% to or more independent of BCR-able signaling. So that could have been there. And certainly I cannot comment that looks like he was compliant to the medications because he did have BCR-able of 6.7 at one time. And he did develop thrombocytopenia while on dasatinib, but recovered on nilotinib initially. So the compliance seems to be there. But I have a feeling that this patient had an intrinsic resistance, which may be other than 244V, which is usually sensitive to dasatinib and nilotinib. And whether I could have done something different, well, if the availability of the other drugs were there, one could say that one could try either ponatinib, or if the disease acceleration was there, sometimes people can use a combination of ruxolitinib and TKI to overcome some sort of this resistance, or even sometimes low doses of cytidine to get this patient into some sort of chronic phase and take him to a transplant, either reduce intensity at that time. But that's my comment, and not much there, except maybe there is a resistance that may have played other than the M244V.
And of course, if anyone else in the audience would like to comment on this case, please feel free. Beppe, welcome.
Yes, I'm Beppe Saglio. Can you hear me?
Yes.
Yes, sorry for my delay, but I was thinking of today at 2 p.m. I do not know why.
Italian time.
No, it's just to join the discussion, but I will follow the next case. No problem.
Just one more comment that although if one reaches this point that the patient is not responding to multiple TKIs, if the patient was younger, I would have taken him directly to transplant if there was no choice.
Absolutely. I read the case, which is the case in which there was, I would say certainly transplant is the best option. However, he's not responding. I cannot remember exactly the slide now, but is not responding to ponatinib and dasatinib 2 or not, because it's always better to go to the stem cell transplant after induction therapy. Okay, so no, my personal idea is just I'm totally in favor of a transplant, of course, in this case.
Sorry, Beppe, you're in and out. Can you find somewhere with better reception? And in the meantime, Naeem, one last comment and we'll move on so that we stay on time.
I agree with Dr. Olanrewaju that what was done was appropriate given whatever the medications available. And if there's a chance that if the patient has already failed 2 and seems to be the last bone marrow in acceleration, I would take the patient directly to transplant because that's the only chance. But given his age, that looks like it would have been a difficult choice also.
Thank you so much, Olanrewaju.
I have one question.
Amha.
Hello?
Yes,
Yes.
Amha. Yes.
So I was just wondering about the sequence of the use of the TKIs. In a patient with thrombocytopenia, probably dasatinib should have been avoided. Wouldn't it have been better to give nilotinib or bosutinib rather than dasatinib in this patient?
Certainly, the best one is represented by bosutinib in terms of, I would say, bosutinib is the one which is preserving apparent platelets more than the others, but the difference is minimal, and probably dasatinib is the worst. So if we must put them on a sort of scale, I would prefer bosutinib, then nilotinib, and last one, dasatinib, but because we know that dasatinib is also probably causing some problems of platelets aggregation, and so this may further, of course, create a problem in patients with already a platelet depletion.
Yeah, but I think as from what Dr. Lendre, she can give a comment that this patient actually developed thrombocytopenia after starting dasatinib. There was no thrombocytopenia before that.
Yeah,
so
this is important just to avoid and to change the TKI.
Quick response, please, Lanre, and then we must move on. I was trying to be the time police, so we've just gone 4 minutes over.
Okay. He actually had a slight thrombocytopenia before commencing dasatinib, which is why it was started at a low dose and alternate days. And at that point in time, we were out of supplies of nilotinib and bosutinib. So dasatinib was the only TKI available for him that was second line. And if you see that he was commenced on dasatinib in 2021, we had been waiting for supplies for drugs since 2019 when he had the TKD mutation done. So we couldn't keep waiting because, I mean, he was developing a thrombocytopenia, leukocytosis. I forgot to mention we had to put him on hydroxycarbamide at a point to control the leukocytosis. So just because we couldn't keep waiting for supplies of other drugs to come in, we just decided to start him on dasatinib at a lower dose.